countless topics. In this episode, we are joined by Dr. William Hull, who, among other things, is a doctorally prepared neonatal nurse practitioner in West Texas. He is also a NICU parent, as his son was born at 22 weeks gestation. Dr. Hull shares his family's experience in the NICU and how it fuels his professional dedication to parental psychosocial support and family-centered care. Our discussion includes facilitating parental-infant bonding in the delivery room, to the importance of individualizing your approach with each patient and family, to giving ourselves grace in healthcare. We are so grateful that you're here with us. Let's jump into the conversation.
We want to welcome our guest today, Dr. William Hull, who I consider a friend, a colleague, a mentor, and we would love to hear his kind of discussions and perspectives on his experiences, not only as a male nurse practitioner, and so definitely being underrepresented in that component, but also previous experiences as a parent of a baby who was in the NICU. So welcome, Dr. Hull. We're glad to have you with us today.
Hi, guys. Thank you so much. I appreciate being invited into this space and being allowed an opportunity to talk with such amazing people on this panel. It's just awe. I'm just in awe to just be in this space. And thank you so much for that introduction, Tracey. I don't consider myself a mentor to you at all. If, in fact, probably it's the opposite, I would say. But we are definitely have worked together in several capacities. And of course, I've seen Mary talk at NAN and FANAP, and then Jessi as well. I've been able to see you present at NAN, and it's been fantastic. The presentations that you guys give, the wealth of information, the different perspectives have also been just eye-opening and inspiring. As far as for me being a male nurse practitioner, neonatal nurse practitioner, we are very few, but we're out there. We are not as boisterous, maybe, or in mainstream, if you might want to call that. But we are out there, and I appreciate, again, being allowed in this space and being not only bringing that to the table, but also bringing to the table, like you said, Tracey, my lived experience as a NICU dad, and not only as a NICU dad, but a NICU dad to an extremely low birth weight infant on the edge of viability. So thank you, guys.
We are very happy to have you. And I do believe Tracey is a mentor to everybody she interacts with. It's a reciprocal relationship, but that's what makes her such a good mentor, because she's learning and you're learning. And that's part of why she's an integral part of the circle.
Yes. It's just so cool to meet you. I remember meeting you at FANUP, and I don't think I really realized the distinction of being a male neonatal nurse practitioner. And I'm looking forward to kind of getting your take on that experience as well. So super pumped you're here.
Yeah, absolutely. Well, at FANAP, I mean, not to put a plug for them, right? We don't want to plug them, but for FANAP, there was only a handful of men in the space. So, I think we counted 8, definitely less than 10, in that entire room filled with these amazing professionals. So, like I said, we're out there, we're here.
Interesting thing in that aspect is that is more than what you would see from some of the other underrepresented groups, right? Do you know, and I don't know, this is what I'm asking, do you know the current stats for the estimation of male neonatal NPs, or even NPs across the whole?
Yeah, that's a great, that would be a great point. I was talking to somebody at NAN, again, not plugging anybody, but I was talking to somebody at NAN the other day, and there is no number. We have no idea of how many male NPs are out there. I can say that for the practice that I work with, we do have a large male group where we're pretty well accounted for. But nationally, no, that data is not, as far as I am aware, collected. I'm sure NCC does have some of that data, but I have not asked for it personally.
Well, actually, it's surprising that in my last conversation with them, they don't have a lot of demographic, at least from a racial standpoint, right? Because was trying to gather some of that information as well, and it is not collected. And it always goes back to this conversation of why not, right? And is it that we think that people will center on that, or I don't know. I've always been curious as to why, one, people don't collect it, or even two, why people don't answer the question, right? Now, I will say that for some things that I am participating in, I do make a judgment call to not answer the question when they ask race or ethnicity.
Mhm.
And partly because this may sound bad, but there are some things that I'm like, I don't want to be targeted. And so I'm not going to answer it. And I will just whatever, because I think that it will be detrimental to me to answer it. And then on the other hand, it's like, yes, I want to acknowledge that I am one of few Black people who are doing this. So I'm going to answer it because I want you to know that when you're looking at this, there's only a handful of us. And so I just wonder about that from other aspects.
I like how you discerned on that topic, Tracey, because you started to make me think, is there a responsibility for whoever's asking those questions to share, like, this is the reason why we're collecting this information, so that we can better, provide resources or, culturally, responsive information or whatever, whatever the circumstance is. But because I find myself doing something similar. Um, and um, and a lot of times it's because I don't know what you're doing with this information. So I'm just going to, choose not to identify, by those parameters. So interesting topic.
Yeah, kind of venturing into data and then its connection to systematic distrust, right? Of, if we are like this in a system that knows that sometimes it is beneficial to disclose, but imagine what people who maybe not be a part of this system and then have that inherent distrust, and then how much data could we have that could maybe skew to more culturally sensitive, potentially responses, but we haven't created a safe enough environment for people to feel like they can disclose. I was asked to build a demographic survey for a group, and like my first question was, well, why? What are you going to do with this? How are you going to protect this data? Well, we just want to know. I'm going to need a little bit more than that, like what's the plan? Because you're asking some potentially very sensitive questions that everyone has a right to answer or not. And there was also a little bit of pushback because I was like, we need to give a, I don't want to do this, answer. And they're like, well, they just won't do the survey. I was like, well, maybe they're comfortable with telling you their age, maybe, but then they're not comfortable with this particular aspect. I was like, you always need to give people an option to withdraw consent or not participate. And that's true in healthcare. It's true in everything. But I think we don't appreciate that so much, I think specifically in healthcare, because we're so used to having untethered access to everything about someone. I'll just speak to my own experience. I found that a big hurdle being a NICU parent in a unit that I had worked in, because all of a sudden it was like, oh, you have access to my medical records. How do I feel about that? And I would get questions sometimes that were pointed in a sense of about my PHI, and I was like, I don't love that you know that. Right? Even though I don't necessarily have anything to hide, but there's a reason why it's private.
Yeah.
Some of us know a little bit about you, Will, but would you feel comfortable sharing any of your child's story and kind of your lived experiences, and only what you feel comfortable sharing with us?
Yes, I do feel comfortable sharing my son's story and our story as well. My son was born at 22 weeks and 1 day, so literally at the cusp of viability. My wife went into preterm labor with an incompetent cervix and then a bulging bag. So, I mean, what we see typically in the NICU, right? Parents just come in and, oh, there's a baby and we're about to deliver, right? And let's try and hold off as much as possible, right? She was on bed rest for, I want to say, a couple of days, made it through the steroid window. And then next thing you know, my son's head was in the canal with the bulging bag. And they're like, nope, it's time. We got it. We can't risk it anymore. And so, and pop the bag and out he came. One of the things that I always remember is the neonatologist being so delicate with us. We were so blessed to be in a facility where my mother-in-law was the NICU educator. So she knew, and my mother-in-law in our area that we're in, she kind of like led the charge on NICU and NICU education for all the facilities. If you bring up her name, everyone knows her. She's just one of those super amazing people who's just so nice and so personable. And I am blessed to be able to even say that, right? We hear all those stories about mother-in-laws and how there's that clash, and no, there's none of that. She is also just awe-inspiring with the knowledge and the ability to create change in this area. So again, we were very blessed to be at a facility where she was the NICU educator. She's a CNS, clinical nurse specialist, specializing in neonatal care. And so I don't want to say that we got the care we did, and I don't want to say that we got preferential care or anything like that, but it's underlying, right? It's there, right? So if, a Joe Schmo family at 22 and 1, I would hope that they would get the same care we got. I would hope that it would be the standard of care, right? And not that we got extra care or anything like that. So anyway, let's talk about life. Let's talk about long-term outcomes. Let's talk about, are we going to resuscitate? Are we going to provide comfort care? And unfortunately, as a NICU parent, when you're in that situation, you have no way to react. You have no idea of what is being said at that moment because it's all traumatic and it's all just coming at you at one time, right? You're supposed to have this, the idea of a beautiful birth, beautiful pregnancy where it's just fantastic. You make it to 40 weeks, moms get to breastfeed, get to go home, do that whole care and all that. And that wasn't the case for a lot of our NICU families. It's not the case. So our neonatologist, the one who came in and talked to us, I have to give her so much credit. She came in with such compassion, and she came in like, okay, what do you want us to do? And that's how she said it. And me and my wife were like, we don't know. My wife, is trying to hold off contractions, and she doesn't even remember the conversation we had. And we were like, well, you're the neo. I mean, you tell us what we're going to do, right? And moving into this role as a provider, I actually see that a lot more and a lot clearer. That the NICU families, we try to give them autonomy. We try to let them make the decisions, and they can, unfortunately. They have no clue of what they're signing up for or what they're not signing up for. And so we basically put it in our hands. We're like, well, you decide. How are you going to do it? You're the professional. You decide. And she's like, okay, well, if your baby makes an effort, then we'll do everything. If your baby comes out and doesn't make any effort, then we won't. And my wife and I are like, okay, all right. That was clear, cut, to the point. He cries, you do everything. If he doesn't, okay. And of course, again, my wife and I were very, I don't want to say ignorant, but didn't know. We didn't know. We didn't know all the intricacies that go into having an extremely low birth weight infant. We didn't know the risks that were assigned to it, right? They came in with percentages. They came in with, oh, your baby has X number of percent of living, X number of percent of mortality, X number of percent of not being able to walk, talk as he gets older, just depending on the NICU state. I have no idea what that means. What does that mean to me? Right? And if we, as providers, we give these numbers and we give these outcomes to these parents. And again, it goes back to, well, okay, I hear you, I understand you, but I have no idea what that truly means later on in life. I have no idea what I'm signing up for, right? So, like I said, I hope we didn't get like the peripheral treatment or anything like that. But our NICU baby was in the NICU. He stayed maybe a week after his due date, and he had a beautiful NICU stay. Had the most he had was a grade 2 IVH, no neck. Of course, had a couple bouts of sepsis. I mean, what NICU baby doesn't get through NICU without a little sepsis? My wife was a champion, provided breast milk as best as she could. And so he went home on a breast milk diet. And his growth was beautiful, and, he's just amazing. And I really truly owe it all to the NICU staff that took care of him. They were amazing. Of course, my mother-in-law, I give her, extreme credit, because she was so good at saying, I'm a NICU grandma. I am not a NICU educator. I am not going to input any of the information I know. I'm not going to butt in with anything. I am grandma. And she was so, and again, I have to give her so much props, because I'm a grandma today. I'm a grandma when I'm visiting. I am not the educator. Do not ask me education questions, because I'm not going to tell you. And even like with the NICU nurses, they respected her boundaries as that as well, which I give them extreme props as well. And of course, my wife being just an amazing stronghold. And I don't know how much I was a stronghold for her, but we were able to make it through. And I think, moving from a NICU stay with acute and chronic illness all being thrown in your face to being outside of the NICU is a completely different life experience. And I think one that is not talked a lot about, that we don't look at, and going from that transition of having monitors flash in your face 24/7 to just complete silence and being completely alone. That was a shocking transition, I would say. My wife, we were both in nursing school, so we were both extremely young and both didn't know. And in nursing school, we don't talk about NICU care. We don't even cover a glimpse of NICU care, especially in undergraduate education. So she was able to graduate, and I took time off, and I was the primary caregiver for my son. And we were blessed again enough to be able to be in that situation where we could have that ability, where someone could stay home and somebody could go to work, and we could alternate, right? He didn't have other siblings at home. He was our firstborn. So again, that's a whole nother aspect that we don't talk about in NICU care or in family-centered care, is if they have other siblings. What does that look like? How does that play into it? Again, like I said, I was able to stay home. I was able to do the therapies. I was able to do all of the PD appointments, especially with being a 22-weeker and having all the subspecialties that go along with being a 22-weeker. I'm sure your listeners are aware of what that entails, but it's definitely more than 3 as far as specialties and appointments go. But again, I think the outlook we had was just a blessing, an amazing blessing. And where he is now, he's now a rambunctious 13-year-old who thinks he knows everything. And we just kind of have to gently guide him back to real world and say, no, you don't. You're still our baby. But yeah, that's our story in a nutshell, and went on for a minute.
Wow.
So in your experiences, I think that, I know for me, sometimes I feel very uncomfortable with myself, with how I am interacting with a partner, because I can look at a birthing person and say, I know how such and such feels, right? Because I've done that. I've given birth. Can't say I know how it feels to have a baby who is preterm or sick in the NICU, but sometimes I don't feel like I can say that to our fathers specifically, right? So what advice would you give, being on now both ends of that spectrum, now being the provider, but also having been the father?
Yeah, that fortunately, unfortunately, whichever way you want to look at it, is such a loaded question. And there's no way to give a true, answer that's going to guide anyone a certain way to do any certain thing. I hate to say this, right? But stereotypical males want to fix things. We want to go in and we want to be like, okay, I know what I need to do, and I'm going to fix this right here, right now, and we're going to get this done. I remember one of the things that I try to pass on to other providers and NICU nurses and students, because I'm also faculty. I teach in the NMP program, and I also assist in offering lectures to undergrad, just to give that little glimpse of NICU care, right? So what I try to teach to all these people, all these different individuals, is that we need to give the dads a sense of purpose. give them a sense of direction. Where do they need to go? What do they need to do? Don't look at dads as a bystander or as a visitor or as something in the way. I remember when my son was born and he gave this big, huge cry, and there was so the way his birth is just it stuck to my head. I mean, every person's birth is gonna stick in their parents' head, right? But when he came out, he just shot out, and everyone just paused, and you could just see, and everyone just even no one was breathing, and finally he let out these two big cries, and then people swarmed him, and it was amazing to see. And immediately they, the NICU team that was there at the delivery intubated, got him all draped in the sterile gauze or in the plastic wrap, and put him in the transporter and transfer him straight to the NICU. It was so quick. But I remember standing there and just being in awe and just like, what just happened? What did I just witness?
Mm-hmm.
And my wife is there, and the OB's working on her, trying to get her all situated. And I remember just like looking at her and then looking at my son and being torn. Who do I go with? Who do I sit with? Do I stay with my wife? Do I follow my son? And then I remember the NICU team looked at me and they're like, follow us. You're coming with us. And I was like, what? What do you mean? And so then I remember just standing in the hallway. My wife they had to pull her back into the OR and from the L&D suite and put her in the OR. And I remember just standing there, just being like, and finally somebody grabbed me and was like, you're following us. And I was like, okay, I have a sense of direction. I have a purpose. So when I start educating other people, I always say, make it a point to talk to the dad. Make it a point before the delivery. Hey, dad, or support person, or whoever you are following me.
Yeah.
We are going to tell you when we're leaving, and you are going to follow us down to the NICU, and you're going to see where the baby's going, or whatever bed space your baby's going to be at, right? I do that a lot in my education, and I reinforce that. And then when we're in deliveries, I always tell the NICU staff, okay, make sure you get dad, or the support person, have them follow us down, right? Another thing is what I don't quite remember if my wife was ever able to see my son before being transferred to the NICU. I don't recall. But another thing that I make it a point to do is allow moms to see their babies. They have to see their babies. If the baby is stable enough, let them touch the baby. Let them hold the baby. Let them give a kiss to the baby. Allow that micro bonding to occur before you completely disrupt this entire process, right? And I know my nurses get a little frustrated with me because they're like, William, the baby's intubated. I don't care.
Yeah.
I don't care. Hold the tube. Let baby and mom bond, please. So I stress that. I am big on family-centered care and parent interaction. That is a big, big stronghold I have in my professional practice. And of course, I think, unfortunately or fortunately, whichever way you want to look at it, I think having that parental side, other people don't have. And I'm able to bring that forward. And I see when I'm talking to NICU parents too, especially when we get in that lull of the NICU stay where we're literally just waiting on feeds, and they're like, my baby just needs to eat. My baby just needs to eat. And I tell them, I say, look, this is the most frustrating part of your NICU stay. This is the boring part. This is the part that frankly sucks. And that's literally how I explain it to them. This part sucks. You're literally just waiting for your baby to eat. And I say, the best you can do is be here as much as you can. And I also add, as a NICU parent, I remember being at this very spot and losing my mind. And when I say that, you could see like a little, oh, you've been here. Yeah, I have. And I can tell you, other people can't, but I can tell you, this is one of the worst times to be at. So I always try to make that connection with parents and always try to have that little moment. Like, okay, you're not just a provider coming in and telling me what I should expect and what I should do. No, you're somebody who understands because you've been on this side.
I love how you described, how the team said, grab dad, you're coming with us. It brought me back to when you initially started to share your story, and the neonatologist was asking you, what were your plans? What did you want to do? And I think, I mean, although I admire, that approach to care, I think the small piece that might be missing in that, genuine, wanting to provide autonomy and engagement with the family is the fact that, and you described it so perfectly, these folks are in shock right now. Their cortex is offline. And so, but it's important to, you know, um, create like the awareness that, like, I'm the provider and I do want to partner with you in this, but maybe, the next step is, and I understand that you are scared out of your wits right now. I understand that this is overwhelming and no one is prepared for this kind of situation. And so, and then, you kind of have the discussion and you guys, I love how you described it because you just were like, I don't know, haven't done this one before. You're driving the car. We'll take your lead. So you want that level of discussion, if you will, but you have to acknowledge that this is not normal and these folks are
Mhm.
freaking out. And the way you described that, place where you were, that indecision of like, do I go with my son? Do I stay with my wife? Oh my God, with also short circuiting, this cortex is offline.
Mhm.
So I love that the team recognized that and immediately, brought you in and made you part of the team in that
Mhm.
moment. But, kind of, it's so standard for, I think, um, for us to often get caught up with the medical crisis in the moment,
Mhm.
say, oh, this is not important. And so I applaud you. You are the bee's knees, my friend, to really emphasize to these, new nurses, whether they're, undergraduates or nurse practitioners, the power and the critical nature of that, initial connection, with the baby, because this may be the last time they will ever see this
Mhm.
child alive. And so you have to be aware of that and you have to make that a priority. You have the skills. You can tube these people. You can do the things. But what you can't do is change this moment because it's once it's gone, it's gone. So thank you so much for
Right.
sharing that. That was absolutely beautiful.
Of
Yeah,
course.
it's kind of eliciting preferences, right? And then assuming when you can't, right? So
Mhm.
asking, how do we want to manage this? Whether it's something as life altering as do we, resuscitate or not, which is a hell of a question, right?
Mhm.
Or is it, what nipple to use or what time bath is, right? Like elicit the
Mhm.
preference. And then if they have one, honor it when at all possible. If they don't have one, then offer your compassionate, understanding to try to make sure, okay, this is where I'm at. How does the temperature read on that when the time allows, right?
Mhm.
Um, and I think that sometimes is where we lose it because we'll say, what do you want to do? Oh, he doesn't know. We're just going to do everything. And you're
Mhm.
like, okay, yeah, but there might have been some, roadblocks along the way. I mean, I listen just thinking of my own professional side of my career and listening to some of the conversations I overhear with, teams. And I'm like, I mean, I think this one is one we should ask them about. Like this one's a safe one.
Mhm.
And they're like, oh, we'll just do it. And I was like, okay, y'all, it's not our baby
Mhm.
in the end. But like, yes, act with that compassion. Cause like my story, of course, is very similar, but opposite in some ways. Cause I wanted them to tell me absolutely everything
Mhm.
because I was a professional first in that moment, despite
Mhm.
everybody asking me to not be. Because in a sense, because of my trauma response, my ACE score 7, my hypervigilance, all the things we spent all the time talking about, my cortex was super engaged. I
Mhm.
wanted to
Mhm.
know everything.
Yeah.
And that really threw them off because they were like, wait, oh, okay, you have questions. And I was like, of course I have questions. I want you to give me a report on this baby and then answer the questions I have that you're going to hate. But but it also, there were times though where I would kind of like what you said about your mother-in-law, where I'd be like, yeah, okay, that's not for me. Y'all figure that out. That's just your policy and you
Mhm.
not understand it. That's for your educator, right? But then there were
Mhm.
other times where I'd be like, did anybody teach you how to do this? Because
Mhm.
I'm about to. Like,
Yeah.
so it was like finding that line. And I get a lot. I'm a lot. I know I am. But it was also asking them
to accommodate that and at least attempt to build that relationship with me in this role that nobody asked for. I didn't want this. They didn't want this. My baby didn't want this, but here we are. Right. But to your point, if they had just asked, right, we could have avoided some of that and maybe aligned more with expectations for everybody.
Yeah.
I think too, what makes it very difficult or challenging is that we like, in the NICU, we like to have everything in a box and everybody is in a box and all our babies. Okay, we check our boxes, right? We're very type A. We have our boxes to check. We have our things to do, our tasks to get done. And unfortunately, family is not like that. And even though we want our families, and that's been a big learning curve for myself is I always, I get in that assumption that, oh, the family's going to be like me and we're going to be great and we're going to, just chat and everything. No, that is not the way it is at all. And so you have to tailor this special art of being able to relate to the families or being able to make that connection with the family so that you have that transfer of information because it is extremely, extremely overwhelming. And sometimes we get to the point where we're just like, okay, we've talked about this 10 times. What are you not getting? Right. But at the same time, we still have to be patient with them and be like, okay, let's talk about it an 11th time. Yep. And that's another thing that I pass on to the staff and learners as well is when parents ask the same question over and over and over and over again, they're not looking for a different answer. They're not looking for, sometimes they are, but they're not looking for that. Instead, what they're looking for is, I didn't get that initial information. Can you repeat it?
Yeah.
Or you have a neonatologist or an NP who speaks very medical, right? And they're like, I did not understand a word he said. Can you explain it again? And then they keep asking for that reason, not necessarily because they're looking for or hunting for different answers or looking for the whale, right? They're not. And I think now too, we're also moving into an era with AI where parents are AIing what's happening with their babies. And you have to go back in and kind of undo what they read. And you're like, well, that's great for what AI said, but that's not necessarily your baby, right? It all goes back to individualized care. And unfortunately, with families, it's messy. And you have to do individualized care for each family member and the family unit when they're together, right? So that's what I've just learned in this process.
I think you're calling out safety as an issue. If I don't feel safe, it's really hard for me to process what you're saying because I'm too frightened. I don't feel safe in this space. And I think, kind of following up, Jessi, on what you said, not feeling safe can manifest in a variety of different ways. So, if I don't feel safe and my adaptation to that is to get super hypervigilant, super drill down, I need facts, I need specifics, and I may not be able to retain that information in this moment just because of the physiology of how, not feeling safe operates, and it doesn't lay down memories and stuff. I have to feel completely calm for that to happen. And so I think you're calling out some really important aspects of the experience that hopefully, clinicians can dial into that and realize, as you said, this is about relationships. I can't, if I've never seen you before and my little family member is potentially going to die, you're all strangers. I'm scared out of my mind. I know you have the skills because you're employed in this hospital, but I don't know if I can trust you. I don't know if I like you. I don't know what the relationship is. And so helping people realize that that's foundational. You already know all the skills. You can do all the do's. The challenge that I find, at least from my experience, was building those relationships, as you said, getting out of my own way to feel the discomfort of trying to create a relationship with a brand new stranger.
Under the time crunch and intimacy of a birth, you know what I mean? Like there's a lot going on.
Yeah. It
emotionally, physiologically, like there's a lot going on in all of us, right? Even if you just remove the family from it, which is a sentence I almost never say, but even if you just remove them from it and you think about the clinician's experience after a delivery akin to your son's, usually we walk out of the room and we're like, oh gosh, okay, I need something to drink, I need to sit down, or I need to finally eat. Like we have our own needs that are flooding, the vibes, if you will, that then are in, reciprocal to the family. And then you're like trying to make a mess of this tornado that just happened.
Mhm.
That's also beautiful because you have this beautiful life
Right.
that's in front of you. And you're like, this is just so many things all at once. And I'm grateful and appreciative and aware of every single one of them, but how am I supposed to catalog all of that and do it the right way? I don't know that there is a one right way, right? Which is why I usually try to stress the need to individualize, right? We love a standard.
Mhm.
We talk about this all the time. We love a standard, start there, but then individualize to the individual needs that you're talking about, the patient, your team, the family member, each individual family member, so that we can figure out what exact key unlocks this door rather than just keep putting the same one in and being like, I don't know why this isn't opening.
I love how you
Right.
said that. That standard almost becomes a touchstone. And
Mhm.
then you touch that, and then you have to translate it to this unique situation. I loved how you described that.
I think another thing to to be mindful of being on our side of the bedside, right, is that yes, you have that acute initial traumatic stress of the delivery, but then there's micro stressors throughout the entire NICU stay. And those micro stressors turn into chronic stressors, which then turn into this inability to process what is happening, right? So I think that's another important aspect to keep in mind when we're working, not dealing with it. And I don't want to say dealing with, when we're working with families, right? When we're trying to bridge that gap of all these micro stressors and the chronic stressors to help them make a bond with their baby, right? And we often see it closer to the end of the NICU stays. And again, it varies on the parent, right? It varies on what their family situation looks like as far as where they're going to, and I don't want to say explode, but where they're going to let it all out, right? And I tell parents, let it out. You can yell at me, let it out here so that way you have it out. And I'm here to try and, one, let you express how you want to feel because those emotions are valid and you need to express them. And two, so that we can get you help. So we can see where do we need to go? How do we need to address this? And unfortunately, you both said it kind of about how it's uncomfortable. It's uncomfortable to have these conversations. Nobody wants to have these conversations because they give you chibbies, right? You're like, I don't want to be a part of that. I don't want to hear any of that. But we have to. That's our point, is to be there. And unfortunately, in the NICU, we like to hyperfixate on the baby, which we should because it is a neonatal intensive care. But you have to also think about the broad umbrella of what that looks like, right? And make that big transition to family-centered care.
Yeah.
Do you find yourself being that person that people are always like, hey, William, I've got this family and the dad is blah, blah, blah. What should I do? And how do you absorb that without it, one, potentially exacerbating the prior stress you had from your NICU experiences and just life stress, right? I know in the literature for other underrepresented populations, they talk about this minority tax, that you're always the person that people come to and say, help me with this situation.
I can say that with my practice, that I don't get sought out. And our practice is really good. We do really good at creating that parent bridge and that being able to explain things in a way that parents understand. So I don't necessarily see myself getting sought out. But when we do give report, we do talk about, well, these parents are a little difficult. This parent is a little difficult on this side, or something's going on with this one, or and when I hear those words, immediate perk up. I'm like, wait, what? Say more. What's going on? Why? What are they saying? What are they doing? How are they acting? Well, have we consulted social service, case management? Have we talked to them to see what's going on, personal? Are they at that point in their NICU stay where they're just tapped out and they're done and their tank is empty? And sometimes I get the response, well, they've only been here a week. It doesn't matter.
No.
That doesn't matter at all. They could be here for a day and their tank is tapped out. Remember, the NICU is not where people are planning to go. It's not what they're expecting. It's not in that realm that we even think about. Parents come into the NICU and they're like, I didn't even know this was a thing, right? So for us, it's easy because we're like, oh, it's the NICU. Yeah, you'll be fine. You have 24/7 coverage, and we're going to be watching your baby all the time, right? Parents, it's not that simple. So when I hear those words, I try to seek out those parents because I want to just make sure that somebody has talked to them, right? And then that's where that conversation comes in. Well, how are you doing? How are you feeling? Sitting down with them does wonders instead of standing up while they're sitting and it kind of looks like you're lecturing them or you're already on a defense, right? I don't like doing that. I like sitting down and getting at eye level with them. Sometimes, I mean, it can feel a little uncomfortable, but if my chair scoots down further, I like them to be higher than me. I like them to be looking down at me. And so they have that perspective that the power is theirs, that their voice matters, right? So that's where I go. And then, of course, I offer, when I ask social services, unfortunately, social services has that negative connotation. It always has that, oh, that's something bad. No, not at all. I'm going to put in a social service consult to see if they can help you in some way. Do you need food? Do you need rides? Do you need a bed? Do you need any type of service? Again, like I said, with our NICU stay, we were blessed that it was our first baby. We didn't have other babies at home. Well, I don't know how parents do it when they have other kids at home. I can't grasp how you do that, how you manage that. And unfortunately, you have parents, I'll have conversations with parents and they say, well, I have a 5-year-old at home and they get out of school at 2 and I'm going to try and get here for the 2:00. Whoa, take a moment, pause. You have to think about that. How are you going to do that? You're going to pull yourself a million different ways. And I think that is one of the big things that as clinicians and as providers, we have to think about is that these parents are being pulled so many different ways. And the tug is there and it's felt. And sometimes they just need an opportunity to release that, right? And that's, I hope that I'm able to provide that opportunity for them to release. So if, anything, I would say if you're allowed or if you feel comfortable doing it, just let the parents talk. Just let them talk. Sit there with them, right? And of course, again, we have our million checks boxes that we have to get through in one shift, but that little talk goes so far for them.
Yeah. Bessel van der Kolk says that trauma is when your reality is not seen or known. And so, when we, as clinicians, it's our bread and butter. We're in and out, this is not a scary place. We're perfectly comfortable here. And we, I think, forget that, and I love that you said that, there's a lot of people that don't even know this is a thing. You don't know about NICU unless you need to be in the NICU. And it's scary. And I think we sometimes get detached from that and just expect people to roll on some kind of linear, pathway from point A admission to point, D discharge, without any disruptions and not realize how this is not just a real tough situation from a medical perspective, but this is upheaval across every single facet of that individual's life. I know Jessi can speak to this, but I'm also a grandmom of a NICU person. And I loved when you shared the story of your mother-in-law and really being very clear about the boundaries of who she was in those moments. Because I found myself also trying to do that because people were seeing me as a nurse practitioner and I couldn't even speak straight. I could not, please don't talk medical to me because I am freaking out because my baby's baby is here and I'm worried about my baby. She has her baby she's worried about. And so I think, really recognizing the level of turmoil that spins off of this one moment that we just see with such clarity. It's just, oh, they're just this. It's like, you just don't know how that has just sent shockwaves through every single facet of that family's life.
We're coming back around full circle to the intersectionality discussion, right? Because no experience is monolithic, no matter how you want to slice it, right? No NICU parent experience is monolithic. No NICU nurse practitioner experience is monolithic. Nobody is going to be that way. So recognizing the intersections when we're privileged enough to see them, because some of them we'll never know, right? Some things we will never know about our families, nor do we necessarily need to know, right? But when we are privileged enough to be shared, when that information is shared with us, we need to figure out how to support that, right? And like William said, sometimes the most simple answer is just listen. Right. I mean, I've said this a few times in pod, just shut up, right? Like stop talking, let them talk, right? And then you'll be amazed what you'll actually find out about what their needs, wants, and desires are when you let them talk rather than coming in with like, well, this is the problem and this is it. I never forget one of the neonatologists, she was like, you have an anxiety problem. And I was like, no, I have an ACE score of 7 and a trauma problem, but you're not going to fix that in the NICU. And he was just like, oh. I was like, I've been in more therapy than you could probably ever understand. Like, I am hyper aware of who I am as a person. I know you are not, because even as somebody who worked alongside you for 6 years, you didn't know this version of me because you didn't get access to this version of me, right? So now you are, surprise, right? And now we've got to figure out how to navigate this. And sometimes people are going to be me and going to be bold and outspoken about it, but most people are going to be more subtle. And you have to find those moments so that they feel safe to feel a little vulnerable and say, hey, you know, I am having a hard time getting here. Do you guys have any kind of programs that could help with gas? I have a car, but I live 30 miles away, you know? But if you don't even give them a chance to say it, they're just going to keep going into debt, you know, or not coming. And then we're going to judge them for not coming when they can't be here. It has nothing to do with their desire to be here. Or knowledge, like awareness, because sometimes we'll be like, do they not get it? No, they get it more than I think we can appreciate a lot. It's just they can't make it happen. Somebody's paying us to be here. They are paying to be here. That is a very different perspective.
Yeah.
Right. Absolutely. And then I saw, an article actually just a couple days ago about how some NICUs are moving to virtual rounds where they call the parents during rounds and like, hey, we're going to update you on your, and I'm like, that sounds amazing. I would love to be a part of that. Let's do that. And then that way you're creating that bond. You're allowing the parent to be a part of their baby, even if they're not there physically present, right? And like you guys all said, and I think we've said it throughout this entire time, we have no idea what's going on at home. Not a clue. We only see what's happening in the NICU at that moment, right? And we can look in the chart and we can see, oh, parent hasn't visited for X number of days, hasn't called for X number of days. Well, have we reached out to them? Has anyone asked them what's going on their side? What is not preventing them, but what could be holding them up, right? And it opens that door again. And then also too, I just want to add there, we can do this, but at the same time, we also need to set boundaries with ourselves, right? We need to be able to say, okay, so that we're not, I don't want to say taken advantage of, but that we're also not overflowing our cup at the same time, right? We have to be able to set our own boundaries and say, okay, I've had the conversation, right? We can revisit it later, but we've had the conversation up to this point, right? So I think because again, in the NICU, we have that it's mentally, physically, emotionally exhausting. Being a provider, being a parent, it doesn't matter who you are in the NICU setting, it's exhausting and your cup will be drained. So we do have to take a moment and realize and have that self-reflection that my cup is drained. I'm tired. I can't do it, right? I have those shifts. We all have those shifts where we come in and like, I'm not going to talk to anyone today. I'm just exhausted.
Yeah.
That's okay, right? But we make it up. We make up for it the next shift. We make up for it, right? Take those mental breaks. Take those time to recharge and reevaluate and be able to fill that cup back up, however you do it.
That's such an important aspect to bring front and center, is how depleting this is for us. But I also, kind of caution us to be aware that while we need each other, right, it can never be felt at that patient-family interface. Like my exhaustion is not an excuse for a family to be harmed in any way, shape, or form, whether it's from a lack of relationship, a lack of communication, or anything like that. And so it really, I love that you brought this up, William, because it really drives the message home how important it is that we collaborate, that we feel safe, that we have real, genuine respect and I don't know, connectedness with each other so that, you know what, I come in and like, you know what, I'm not my best today. I'm here, I can do the job, but can you help me with X, Y, and Z? You know, just like you do in change of shift
Right.
report, like figuring it all out. And I'm going to say, yep, you know, you had me that other time when I had, you know, a tough situation. Yes, we're going to, this reciprocity, this real authentic commitment to each other that just naturally spills over to, you know, protecting and preserving the, I don't know, the dignity of the family, you know, that they're not harmed in our overwhelm.
And that could bring like a whole nother discussion about vulnerability, being
Oh,
vulnerable with each other, being
yeah.
vulnerable with our colleagues, being vulnerable and
Mhm.
voicing that. That is so hard because, again, NICU people, whether you're an NP, educator, nurse, therapist, neonatologist, whatever, we like to say, nope, we've got it all. We're good. I don't need help. I'm fine. I can do this, right? But having that ability to just even voice saying, hey, I am not at my 100 today. I need you to come in with at least 10,
Mhm.
right? I think that's just such a challenge. And like I said, that could be a whole nother discussion that definitely needs to be had.
Back to the safety aspect, right? And not working in an environment that is toxic.
Mhm.
But I also think that that goes back to what Mary, Jessi, and I have talked about all along is kind of the theme for these conversations is allowing yourself to feel safe so that you can share and then taking it back to the original thought of the circle time is knowing who people are as people so that when you do have that day you can say, I know this is not like you, right? Like, even if maybe I don't feel comfortable enough saying to you, Jessi, I'm not okay. You have had enough conversations with me that you can say, you're not okay. How can I help? What's going on? Is there anything, or whatever? And so I think if we could just go back to talking to each other as human beings, that would go a long way to helping that component.
I think too, also giving ourselves grace and giving other people grace, right? I think that's a big, whenever I come into the facility, I'm like, I have to take a pause. I have to take a moment, give myself grace. I may not be at my 100%, but that's okay. I'm recognizing that and I'm going to try to get to my 100% as much as possible, but there's still that grace there, right? Same with our colleagues. We need to give them grace, right? Same with the nurses or therapists or neonatologists, the family. If anything from this conversation, give the family grace, please. This is not what anyone expected. This is not what anyone wants. They don't want to be here. It's okay. We need to allow them to say that. Let them say that. And in a judgmental free zone,
Mhm.
right?
Right. Give permission. That comes along with the grace, right? To ourselves and everybody that interacts, right? Permission to step away if needed, permission to ask for a pause, permission to be angry. Like none of this, you didn't want this. That's okay, right? Like it is okay to not be super stoked about how your life is going right now, right? I know Mia and I frequently when we speak, we'll both make a reference to like, when I got that positive pregnancy test, I did not hope to spend 6 months in a NICU, and no one does. So it's just recognizing that like every day they are doing the same thing. They're taking that pause, they're guarding this and then trying to prepare based on all of their past experiences in the NICU and out of the NICU, how to get through not only for themselves, but for this vulnerable little person, right? That they are trying to be strong for. And that they're trying to be strong for the community in which that vulnerable person is attached to, right? Because you think they come and talk to one parent and then like, okay, now I got to call the phone tree or I got to call this person. And like, well, it's great to reach out for support. Sometimes you're like, I can't say this one more. I can't do it again,
Yeah.
So permission to be angry or upset or sad or grieve or whatever word you need, right?
Right.
Also permission for joy, because I will tell you, there were some good laughs that were had in the NICU, right? And it was this juxtaposition of the two that was kind of wild, but I also I remember those, right? These moments of just sheer pride and happiness. Like the first time she finished a bottle, you would have thought I'd never fed a baby before. Even though I had 2 kids at home and had fed hundreds of babies throughout my career, I was like, this baby is amazing, because she was and still is. Okay.
Yes.
But it was just this moment of like, I needed somebody, anybody to just be like, she did it, and God bless, one of them was like, well, I do know, but right now we're happy. Okay. Right now we're happy. I know we still got like a month ahead of us. And like you said, it truly sucks, that part of the NICU. But I'm happy right now. Can you just be happy for me now? And she's like, oh, yes, yes. Okay, let's get a sticker. We're going to clap, like, all of that. But permission to be human in the end, right? In all the ways that presents.
Right, exactly. And I think also allowing, I guess, along the lines of permission, letting them voice it. Letting them voice it. Say it. Absolutely. That's why, again, when I sit down with the parents and I'm like, okay, you're feeling a certain way, tell me. Word vomit on me. Let it out. I'm here for you, whether it's a joyous occasion or something really bad, whether I'm giving a diagnostic result or we're talking about the baby fed and finished 70% of the feeds. Yeah, be excited, right? Go home, get a burger on your way home, something. Be excited about that. But again, letting them voice it, because if they internalize it, it's going to build up. It's going to build up and it's going to build up. And that's one thing that I've seen. And I can self-reflect on that is we didn't verbalize and we kept it in and we kept it in until we got to that point in the NICU stay where we had the explosion. And Jessi, you talked about this at the conference I saw when you presented on your NICU stay, how you were those perfect parents, the perfect parents. I'm okay. Yes, we're the yes parents. Whatever you say, yes, 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 yes. Until that one moment, and it only takes one moment where there's a switch. And you're like, I am not the perfect parent anymore. I am tired. I am frustrated. I am upset. And allowing the parents to verbalize from the beginning, from the admission, and letting them have that opportunity to say what they're truly wanting to say throughout the NICU stay, not sporadically, but throughout the entire stay, and even after the stay, will do wonders. I believe will do wonders for their emotional state, their physical state, their mental state, the bonding. I think that I am a true believer in that.
It's so simple, but just do it,
Mm-hmm.
and think of how far reaching that is. And I usually will tell people, honestly, even from a selfish place, it makes your job easier, right?
Mm-hmm.
Because yes, it's uncomfortable to, bear witness to that and involve yourself with it. But also there's less other confrontations that are really about so many other things than the thing you're actually, talking about. So if you give them that permission and ability, encouragement even to say it, it just makes the partnership that much richer,
Absolutely. The partnership is key. I think when, like you said, you think about just the one thing that breaks the camel's back, that one little straw, it wasn't the straw. Let me tell you what, it was not the straw. This started on admission.
Yeah.
This was something that built up until they came to the straw, saw the straw, something as silly as, I don't know, a nipple flow, right? Changing the nipple flow, something as silly as that. And boom, that destroyed the whole conversation and world. And it is the end of the world. But it wasn't just that nipple flow. It wasn't. And I think that's extremely important to realize and allow the parents to verbalize. And again, goes back to that grace and that vulnerability. Let them have their moment. Let them say it. It's okay, right?
This is such a cool discussion, because that whole idea of letting them speak and and sharing their truth is actually you're giving them the space to metabolize this trauma that they're experiencing in real time. And if you can, just like anything, right? Like, how things metabolize, that's a good thing, because then you break it all down and you get rid of what doesn't serve you. And then, you pack along wherever the stuff that is the gold. And I think, kind of speaking to what you said, Jessi, about, sometimes you do feel, as a clinician, you feel like, I don't have time for this. I've got to go do these other things. But again, offering up that space and grace, great choice of words, and being that active listener for that story, actually just that pausing in that moment, at least for me, when I wish I had done it more often, made me realize that my presence, I didn't have to say anything. I didn't have to prove anything. I didn't have to do anything. I just had to sit there and listen was one of the most magical, powerful, healing things I could have ever done. And although I used to get big dopamine rushes off of putting in PICC lines and stuff, actually sitting there, and I like the way you described, at eye level or even a titch below, you just felt you were just creating this really sacred space that was full of healing, healing for the family, but I think also healing for us so that we get to peek behind the curtain because we're stuffing it down too, right? I mean, you don't want to bring it home. So maybe you scream or you sing on the car ride home and try and process all the things so that you don't bring it home, or you do bring it home, but it's in there. And so I think sharing those stories enables you to also metabolize what you're bearing witness to as well. So super awesome, William. I just love how you describe these really human experiences with such care and reflection. You're awesome.
Thank you. I don't know about that, but thank you.
It's the truth.
To do the virtual rounding, it sounds like another project, right? Like it sounds like a 2-hour project where you could implement that within your institution or somewhere else, and then we could gather data. And I'm just saying, so you let me know when we're ready for that project, okay?
We should
Because
have a
I also
strong
think-
listener base in all NP schools because Tracey is constantly dropping projects. Like you need a project. Tracey is your girl. She's gonna give you something.
Well, because you could look at it from the aspect of, do you just call them? Because one of the hospitals that I work at now, that's what they do, right? They give a call and the parents are present during rounds and whatever. But then also you could take it the next level and you could get iPads and you could FaceTime them or some other type of video so they could really be present. And again, parents on admission decide, what would you like to do? Because it may not work for every parent because I may be at work. Can't do that, but you can definitely call me or I can call you after. I'm telling you, I got the whole project designed. Let me know when you're ready for it.
Thank you so much, William, for joining us and for sharing your family stories and your professional stories with us. You're making a difference, right? And I love to say this to professionals because I feel like we don't say it to each other enough. You don't owe anybody your story. You don't owe anybody your experience, but you've recognized that this is a voice that isn't as loud, and this isn't a voice that isn't centered all the time in medical spaces, especially in the training arena. And that's when we need to hear it the most, right? Like have those common through lines of lived experience. So I just want to say thank you as a fellow professional and fellow NICU parent for centering that in your education with all the different learners that you're with and role modeling it real time on your unit. Because that alone can change somebody's mind to see that, oh, well, look at how different things are. And this person still lived. Nobody got fired or died. This actually is a good thing. Mm-hmm. So I just wanted to say thank you professionally for doing that. And thank you for sharing your story with us and for entering the circle. It has been an absolute pleasure to have you.
Well, thank you guys. Thank you all for letting me be here and chatting with these amazing bigwigs and family-centered care and trauma-informed care. I truly appreciate it. Thank you, Tracey, for asking me to join. Reaching out and just opening that door. I truly, truly appreciate it. Thank you, guys.
Timeless Topics is Jessi Barnes, Tracey Bell, and Mary Coughlin. It is produced by Jessi Barnes and music from Carlos Bell. The thoughts and opinions shared here are those of the individual speakers and do not reflect the official policy or position for any of the speakers' employers or any other affiliated individual or entity.